Kumar and Professor Bhupinder Sandhu. Also, a warm welcome to Dr. Kavita Chintala and Dr. Krishna Kumar, our speakers for tonight. It's indeed been a pleasure and an honor to as well. I think it's very not. I thank the Global Association for Physicians of Indian Origin and also Indian Academy of Pediatrics this international series lecture, where two important topics are going to as we go along, and there will be an opportunity to answer your questions. So please continue to go along. Before we start the formal sessions and talks, first I would like to of the Global of Physician of India, Professor Sibal is a medical director of Apollo Hospital Group. He's a senior consultant pediatric gastroenterologist and hepatologist at Indraprastha in New Delhi. Sibal has served on the executive council of the International Pediatric Transplant Association, the Asian Pan-Pacific Association of Pediatric Hepatology and Nutrition, and the Pediatric Gastroenterology and Nutrition. He's lectured extensively in India and abroad. And Professor Sibal is an author of a national bestseller, Is Your Child Ready to Face the World?
Thank you. Thank you very much, Habib. Good morning, good afternoon, good evening to colleagues from across the globe. Delighted that the Indian Academy of Pediatrics, under the able leadership of my dear friend, Dr. Ramesh, has reactivated and rekindled this association that we had, which started last year with Bakul and Dr. Tandon bringing us together. Really happy that we are doing this today, and this is the first of many. We hope to do at least 8 or 10 this year. And so happy that the topic that's been chosen this time is so relevant because there's just so many doubts that pediatricians have about managing, whether it's rheumatic heart disease or congenital heart disease, when to refer, when not to refer, who to refer, what to say to the families. And there's just so much growth in this space, and the knowledge that we have today has enhanced considerably. And the options that we have, whether it's surgical or whether it's interventions, have expanded greatly. So really delighted, Ramesh, and I'd like to thank the IAP leadership for restarting this collaboration, and we look forward to some amazing learning experiences as we go along. Thank you so much, Habib. And a big thank you to Bhupinder for joining.
For your remarks and welcome. And I'd like to now introduce Dr. Ramesh Kumar. And head of Department of Pediatrics at Apollo Adlux Hospital in Delhi. Dr. Ramesh is the past national president of Environment and Child Health chapter of IAP. And he's a Environmental Health Technical Advisory Group of International Pediatric Association and Technical Advisory Group of South Asian Pediatric Association. Dr. Ramesh has given 6 orations and has served in editorial capacity on chapters textbook. Please join me in
Thank you, Dr. Habib, and Chairperson, Dr. Bhupinder, moderator, Dr. Habib, and my dear friend, my academic head of the Apollo Group, Dr. Anupam Sibal, as well as Dr. Tandon, and all the faculty for the day, Dr. Krishna Kumar, my dear, from Amrita, as well as Dr. Kavita Chintala from Chindala. It's good evening from my side here, out here in Cochin, but I believe our friends are there from across the globe, and it's good morning again to many good friends, and good afternoon. It's some greetings from the Indian Academy of Pediatrics, and it's my great pleasure to join you on behalf of the Indian Academy of Pediatrics in this opening session. As well, very much my sincere gratitude out there to Dr. Tandon for all these initiatives and the perseverance, because we are out there down with the COVID, most of the sessions. So once now that we were a little late to catch up with, we had the national conference last month, and maybe that is time when we really worked on this collaboration coming back. And it's quite heartening to see we see that the GAPIO IAP collaboration has picked up well in the last 1 year with so many monthly sessions capturing worldwide attention, I believe, from our good friends. And those sessions were very, very resourceful for having some latest updates from different parts of the globe, in fact. And even today, you can have Dr. Krishna Kumar, and I know him very well for the last 20 years, and a pioneer in congenital heart disease, and basically I've done a lot of community cardiology work in cardiology too, a lot in the tribal areas, and I've seen him working there. So it's so thoughtful that Dr. Krishna Kumar is here, and well, of course, Dr. Kavita is also here, and Dr. From the IAP side, I feel we are really privileged to have this collaboration with the GAPIO working once in a month at least, every Saturday, and certainly our guys, we really are looking forward to having some better equipped in some new territory every time we come across with our friends for this session. So once again, my congratulations to the team who worked behind this GAPIO IAP collaboration, and my warm greetings from the side of Indian Academy of Pediatrics on behalf of my office bearers, President-elect Dr. Upendra, and Past President Dr. Piyush Gupta, and my Secretary General Dr. Dinesh Saxena, and on behalf of 36,000 plus, now the strength goes to 37,000 recently, last month. So we are hardly 50 away from 37,000, the latest update. So that's a great landmark and we are running very close to American Academy of Pediatrics title. So that's a great from our side, and I believe we are really privileged to have this session together, and look forward to very, very enlightening sessions on every monthly basis. And thanks again to the whole team who worked behind, and looking forward to a great session here today with Dr. Pubinder and Dr. Habib taking the lead, and the faculty out there. Thank you very much. And
thank you, Dr. Ramesh Kumar. I really appreciate all your comments and all the updates. Now, I would like to invite Professor Bhupinder Sandhu, and also I would hand over as the chairperson of the event to take over the event from me. Those of you who joined late, and I'll just like to briefly introduce myself. Again, I'm Habib Buravala. I'm head of pediatrics and a consultant senior pediatrician in Sydney in Australia. And I am a life member of Indian Academy of Pediatrics. And I've also been previously involved with GAPIO sessions. So it's really indeed an honor for me to be, invited to moderate this session. I'll just like to introduce Professor Bhupinder Sandhu. So Professor Sandhu is a pediatric gastroenterologist with over 25 years of experience, and was responsible for establishing and developing the pediatric gastroenterology and nutrition unit at Bristol Royal Hospital for Children, which serves over 5.5 million people in the southwest of UK. Professor Sandhu has been recognized by Her Majesty the Queen with an award of the Officer of the Order of the British Empire, OBE, the third highest civilian award in UK. Professor Sandhu is a member of the Executive Committee of Global Association of Physicians of Indian Origin, GAPIO, and is also the member of the core group of GAPIO Women's Forum. Please join me in welcoming Professor Sandhu.
Welcome everybody to this joint session of IAP and GAPIO. I'm joining you from rather a nice sunny afternoon in the UK. I'd like to thank Dr. Habib Buravala, who's actually working at midnight, because in Australia it's midnight, for your wonderful and generous introduction. I would particularly like to thank Dr. Ramesh Kumar, who I have met previously virtually, and his team at IAP, and Anupam Sibal, Dr. Tandon, and the team at Gapio for inviting me to chair this session. It's a real pleasure. And I particularly value the IAP and the Gapio collaboration in doing the seminars that were done last year. So I'm really pleased that these are restarting again, you're to be congratulated, and long may they continue, please. And nice to see expanding IAP as well. And we hope Gapio is expanding similarly. Now, the session today is on heart disease in children. We're covering two areas, rheumatic heart disease, which is actually a preventable disease because we hardly see it in the UK. It's mostly a disease in the developing world, and hopefully the World Health Organization and the various preventative medical setups are working to lower its incidence. So we'll be hearing about that from Dr. Kumar later on. Our first speaker today is Dr. Kavita Chintala, who's going to talk to us about congenital heart disease. Congenital heart disease is one of the commonest abnormalities that you get in babies. About 1% of newborns are born with congenital heart disease, and it's been changing massively over the last 20 years and it really does need to be managed by specialists. Dr. Kavita is a board certified member, pediatrician and cardiologist from the American Academy of Pediatrics. And she's clinical director of pediatric cardiology at Care Hospital, Hyderabad. Dr. Kavita underwent 3 years of dedicated pediatric cardiology fellowship training at Wayne University in Michigan. She obtained additional training in fetal cardiology from Children's Hospital in Philadelphia and training in pulmonary hypertension from Vanderbilt University Children's Hospital in the USA. So she's exceedingly well trained in an international setting as well as in India. She has vast experience in clinical cardiology, cardiac imaging, interventional cardiology, and perinatal cardiology. And she's published many peer-reviewed articles and has lectured nationally and internationally. So we welcome Dr. Kavita Chintala to talk to us about congenital heart disease in children.
Thank you, Dr. Bhupinder, for that generous introduction. And I would like to thank Dr. Habib Purawala, Dr. Anupam Sibel, Dr. Ramesh, and Dr. Tandon for inviting me to this prestigious collaboration between the IAP and GAPE. So I would be talking about congenital heart disease and its management. It's really a vast topic, and I will try to address the practical issues that would help day-to-day management of pediatricians. So as we all know, it is the most common class of major congenital malformations, accounting to about 8 per 1,000 live births. So if we look at the data worldwide, there are about 1.34 million children born each year across the world and 2.4 lakhs per year in India. And this is according to 2010 data. And we also know that CHD has been a leading cause of infant mortality across the world, not only just India, but across the world. And most pediatricians, are afraid of cardiology because I think there are too many kinds of anatomical diseases. So there are at least 18 distinct types of heart defects with many additional variations. So every set has, again, a subset of anomalies, but then we will try to clarify some of those things. And but fortunately, the chances are better now for treating these problems, and then almost 85% live up to adulthood with a fulfilling life. So the prognosis has improved over the years, and for myself, where I trained in the US and moved back to India, I do see that in India, many centers have developed which are offering care on par with the Western society. So it's a good time to be in pediatric cardiology. And CHD is a global health problem, and recent data in 2010 looking at mortality shows that the maximum amount of mortality, as we all know, is during the infant period. So the slope subsequently falls and kind of plateaus. So the mortality after the infancy is pretty much plateaued, and then in the adult life, again, it goes up. So we are seeing a lot of adult congenital heart disease with a new set of problems. And this data is from recent Lancet publication 2020. It shows the global burden of congenital heart disease. And this is just part of the data that I put here. So this looks at the infant mortality, and the reds and oranges are with high infant mortality, and we can all see the distribution across the world. So it has caused 2.6 lakh deaths globally in the year 2017. This, however, is a decline by about 34% if you look at the 1990 data. So the mortality rates are coming down, and they are inversely proportional to the socio-demographic index. However, we have to realize that the prevalence is same. So the prevalence has not changed across the temporal years, but the number of deaths has decreased. So because more people are living now with CHD, there is an 18.7% increase in people living, which is from 1990 to 2017. So there's a marked increase in adults. And according to 2005 data, there are more number of adults than children living with heart disease in the United States. Similar data from India is lacking. But the good news is that if you look at the temporal trends of survival compared to 1960s, when actually 1950s and 60s is the era when congenital heart surgery has taken off, compared to that time to 2008. So there is a steady decline in the mortality rate. And this is attributed largely to several treatments that have evolved over time. So I think pediatric cardiology has been exciting for me because I've seen, the technology develop very rapidly. This is one area where over from 1960s to 2000, the area developed very rapidly. So it could be, from an ancient CPB looking machine, which was a very huge machine, to now we have very compact pulmonary bypass machines. There are improvements in oxygenators. There are now pediatric small oxygenators available. There are several myocardial protection techniques that the surgeons employ, and the surgical techniques have improved. So not just this, there are other things that are going well in pediatric cardiology. So the interventional techniques have also developed drastically. So we have several procedures like atrial septostomy, stenting of the duct, radiofrequency ablations that are now performed regularly in cardiac catheterization labs, and many neonatal interventions are performed, which has helped increase the mortality rate. And of course, we have the prostaglandin E1 that has been really life-saving for most of the duct-dependent lesions. The advances also have occurred in the area of imaging, and I've gone through several of these. So there's an upgrade of the echo machine every so often. So we now have advanced MRI available. We have live imaging in the cath labs. There is CT, 3D angio. In fact, 3D printing is also available, and fetal echocardiography and cardiology has also gone a long way in prenatal detection, which has improved the mortality rates. Not only this, we have advances in cardiac ICU. So there are several things available in cardiac ICU to save these little children. The transport facilities and the ambulances with ventilators have developed. And we also have techniques like ECMO and VADS to support these children. And of course, the training, the global training of pediatric cardiologists has added so much. And this, I just would like to show my group of cardiologists where I train. So several of them worldwide have gotten a good training to help us sustain these programs. Now, looking at the several congenital heart defects, as I said, anatomically, there are many, many heart defects, but if you classify them according to their physiology, it becomes much simpler. So the major categories are, as we all know, is acyanotic and cyanotic. Among the acyanotic, the most common ones are the left to right shunts, which are a VSD, ASD, atrioventricular septal defect, and PDA. And then there are obstructive category, which can be obstruction at the aortic valve, pulmonary valve, and coarctation. Now, looking at the cyanotic heart disease, which tends to be a little more complex, I think it is best to divide them into physiological groups rather than worrying about, the anatomy or the single ventricle defects, which can be of many varieties. So among these, the decreased pulmonary blood flow situations, the top is the tetralogy, and other univentricular hearts. So all the single ventricles which have pulmonary stenosis belong to this category. And then the increased pulmonary blood flow situations are transposition of great arteries, TAPVC, the truncus arteriosus, and all the single ventricles that do not have pulmonary stenosis. So this is a very physiologic and practical classification. So coming to management, the session asks for management, but it's definitely not possible to address each defect. So I'm going to give some general guidelines for management. So when we have holes, which are, shunts that I just mentioned in the acyanotic group, we close them. And the closure can be surgical with a patch or by a device, and we'll come to them in a little bit. Then the obstructive lesions, we have to relieve them either by intervention techniques with a balloon or radiofrequency ablation, radiofrequency techniques, or surgically by various reconstructive techniques to relieve the obstruction. Then those lesions that have decreased pulmonary blood flow, whether this be, two-chambered heart or one-chambered single ventricles or dual ventricles, we have to add some pulmonary blood flow. Now, this pulmonary blood flow can be added by surgical technique, which is a BT shunt, one of the aortopulmonary shunts, or of late, we have been stenting the PDA, which remains patent and supplies the blood to the lung. Then among the lesions that have increased pulmonary blood flow, we have to restrict the blood flow with a PA band. Unfortunately, there aren't many intervention techniques to decrease the pulmonary blood flow in the cath lab. Then the big group of single ventricle disorders where we have one pump, we use it for the systemic flow. So whether it is hypoplastic, when it is hypoplastic left heart, the right ventricle is used as a systemic pump. And if it's a hypoplastic right heart, the left ventricle remains the systemic pump. So these are the general guidelines. And when you look at the management, I would first be speaking about critical congenital heart diseases. So critical congenital heart diseases is a list of about 7 or 8 heart diseases that, when not intervened in the first month of life, first 28 days of life, they lead to high degree of mortality. In fact, many of them do not survive if intervention is not done. Now, even among the critical congenital heart disease, I would really put like 3 or 4 diseases on top, because these infants can be sick at birth. Among the critical ones, those that are duct-dependent lesions, those children do well because at least we have prostaglandin that we can start and the babies tend to be stable. But those that are sick and really not prostaglandin dependent are when there's a transposition of great arteries with a restrictive ASD, means there is no mixing across the parallel circulations. The second condition that can be very sick, can produce a baby that's severely acidotic, can be hypoplastic left heart syndrome with, again, a restrictive ASD. So this is a fetal picture. So left ventricle is hypoplastic, right ventricle is good size, and this is the intact septum. So because the blood cannot go into left ventricle, it has to cross from left atrium to right atrium to sustain the circulation. So these babies tend to be very sick. And fortunately, we can detect these prenatally and do an emergent septostomy in these children. Then the other condition that can be very severe at birth is an obstructed TAPVC. So the X-ray looks something like this, a reticular pattern, because the entire pulmonary blood flow is obstructed and it's not getting back to the right heart. So these kids can also be very sick. So these are the ones that need attention soon after birth. Then these are also come under critical congenital heart defects. But as I said, because they are duct dependent, when we start prostaglandin, these kids do fairly well. Among this, again, I would like to divide them physiologically. So those that have decreased pulmonary blood flow, like you have pulmonary atresia, where the blood is not going from the right ventricle to pulmonary artery. It could be a severe tetralogy. Critical pulmonary stenosis, where it's a valve stenosis, but very critical. And then all the single ventricular hearts that have similar pulmonary valve anatomy. So these have decreased pulmonary blood flow, and hence they tend to be very cyanotic at birth. So all these babies need to get started on prostaglandin and then keep the duct open, and then they need to be followed by another palliative procedure before they can go home. Now, these can be a few ways, and fortunately, again, interventional techniques are available. So if you have someone with a pulmonary atresia, where it is a membranous kind, means there's a membrane dividing, then we have something called radiofrequency perforation. So there's a wire that we perforate the membrane that is in place of pulmonary valve, and then balloon dilated, and so there is antegrade flow across from the right ventricle. Then if this is not possible, then we can do an aortopulmonary shunt or a BT shunt, which has been traditionally been done. And then lately we have been doing PDA stenting. So this infant also is having pulmonary atresia, and if you can, it's a small picture, but the PDA has been stented, so it acts basically as a prostaglandin infusion. And then the other set of critical conditions that are duct dependent are the left heart obstruction. So we've discussed sick children at birth, then decreased pulmonary blood flow. Now, these are obstructive lesions which are in the left heart category. So hypoplastic left heart syndrome is the most critical or severe type of a disease. Then you can have critical aortic stenosis, coarctation of aorta, and interrupted arch. So all these have different levels of obstruction in their system, and so need to be supported. The therapies available could be surgical or interventional again. So if you have a critical aortic valve, that can be opened with a balloon, and coarctations that are critical in the newborn also, we may try balloon valvuloplasty or surgical, but this is also available in a child that may be too sick to go for surgery. We can try the balloon valvuloplasty. Then in the surgical repair of these hearts, especially the hypoplastic left heart, entails a Norwood operation where the pulmonary artery and aorta are anastomosed. So this becomes your neo-aorta, works as an aorta. The pulmonary artery is disconnected from the heart, and then there's a PT shunt that takes blood to the heart. And then surgical repair can also be applied to coarctation and interrupted aortic arches. Now, apart from these two, we also have hybrid technologies available, which means a combination of surgery and intervention techniques. So a PDA is stented, so which basically acts as a PT shunt. So the blood continues to go to the aorta from the pulmonary artery. And because the lung is flooded with blood, which is not good for a hypoplastic left heart syndrome infant, we do bilateral PA bands by a minimal thoracotomy. So this is a hybrid technique that is available. And then after that, these are more electively managed. So the ones I discussed are critical, needs immediate attention, and these are more electively managed. This and under this again, physiologically increased pulmonary blood flow condition is a truncus arteriosus, where there is a VSD and common great arteries. So here, this is a surgical condition. There is no intervention technique here. So the surgeon closes the VSD and puts a conduit from the right ventricle to the pulmonary artery, thereby dividing the circulation. Then among the increased pulmonary blood flow situation, we have our common shunts, the one we regularly see from day to day. And these are the ASD, VSD, PDA, and AV canal. So the ASD, a quick look at the management. When they are small, we usually leave them because many of them can close on their own. When the ASD is moderate or large, the technique of choice nowadays is a device closure. And those that are unsuitable for device, we send them for surgery. Regarding the timing, I'll discuss soon. In a VSD, again, VSDs are very variable. There are, membranous, muscular. Many of the muscular ones close, but the small ones, we leave them. The moderate ones who are in heart failure, we may treat the heart failure for some time and then subsequently close them. Again, if they are suitable for device, we do devices now, or if they are not, then the kid gets sent for surgery. And large ones, of course, require surgical interventions. For PDA, most of the PDAs are now closed by intervention techniques with the device, except the silent PDA, which is a small PDA that has no murmur, can be left alone. And we've now recently also embarked upon doing PDA devices in preemie babies. Then AVSD only is amenable to surgical repair. Now, among the devices, we have a huge variety of devices available at our disposal nowadays. So these are all the ASD devices. The bottom ones are the various VSD devices. These are the PDA devices. And I just wanted to show this one. This is a new device called Piccolo device, which we use for preemie PDA. So it is really minute and useful. Now, this angiogram here shows the ASD device that is being unscrewed and closes the ASD. And this one here is showing a small perimembranous VSD catheter in the LV and the device deployed there. And this one is the new Piccolo device that I was talking about. So these infants could be 1 kg, 1.5 kgs, and it's being done. These devices are really small and render themselves well through small sheets. Now, among the more elective ones to be intervened with decreased pulmonary blood flow are tetralogy of Fallot. As you all know, it is a commonest cyanotic condition. And if it is very cyanotic, early neonatal repair can be done. But if it is not, we tend to wait for 5 or 6 months. And basically, the VSD is closed, and then a reconstruction is done to the narrow pulmonary artery and pulmonary valve with the help of a patch. Now, among the obstructive lesions, we have aortic and pulmonary stenosis that the technique of choice is percutaneous balloon valvuloplasty, both for aortic stenosis and pulmonary stenosis. We have some Doppler gradient criteria for when to intervene, and both for pulmonary and aortic stenosis. But this is showing a balloon valvuloplasty being done in the cath lab, and the results are very good. Then the other obstructive lesion is coarctation of aorta, and this can present in the neonatal period, or it can present a little later. Now, the techniques of choice we have could be balloon or surgical. Usually in the neonatal age, we do surgical. Unless the child is very ill, then we do a balloon. Then for older children, we can do balloon angioplasty. And nowadays, for children that are more than 25 kilos or sometimes even lesser, the technique of choice is to stent these narrowings. So this here shows a little narrowing on the aorta, coarctation, and this is a balloon with a stent mounted on it that is going to open the coarctation. Looking at the complex congenital heart diseases, which are probably very baffling to a pediatrician or someone that's just entered pediatric cardiology, these are also can be very simplified. So basically, we look at the detailed anatomical analysis, do a good thorough echo, and analyze the segmental anatomy. So we look at all the segments of the heart, and then we have to figure out whether that heart renders itself to a biventricular repair. So biventricular repair is when both the ventricles can be used to pump to the respective pulmonary and systemic circulation. So to do this, we may have to patch the VSD to the aorta or pulmonary artery. Sometimes we have to do an arterial switch, and sometimes we have to use conduits to put from RV to PA. Then there are those set of single ventricles, many of them where clearly, the ventricle is not usable. One ventricle, either the right or left, is not usable, and they fall into the univentricular palliation. So this could be a hypoplastic left or right ventricle, clearly goes to a single ventricle pathway, or try the respective atresia of the AV valve. So tricuspid or mitral valve, when they're atretic, we cannot do a two ventricle repair. Or when the inlet is only into one ventricle, like a double inlet or common inlet. And then when AV valve straddling, which means it crosses the VSD and goes into the other chamber, or for some reason left ventricle cannot be routed to the aorta. So these are the broad categories which fall into single ventricle palliation group, and these go through stage palliation, and the final stage of all these ventricles would be a Fontan operation. Now, looking at single ventricles, the stage has, like I said, it's a staged operation. So stage one, we look at whether, again, physiologically, is it an increased pulmonary blood flow situation or a decreased pulmonary blood flow situation? When the pulmonary blood flow is decreased, we surgically put a PT shunt, aortopulmonary shunt, or nowadays we do a stenting, a duct stenting to keep the PD open. And when there's increased pulmonary blood flow, which means there is no pulmonary stenosis, then we have to put a PA band, because if the pulmonary blood flow is high, there's pulmonary overcirculation. These babies go into pulmonary vascular resistance issues and are not amenable to single ventricle repair. Then the subsequent stages will be common for all the heart defects. The second stage would be what we call a bidirectional Glenn, where the superior vena cava is attached to the pulmonary arteries and then separated from right atrium. So the blood from the upper body goes directly to the lung. And the third and final stage of Fontan would be called, it's a Fontan. It could be a lateral tunnel, which is inside the right atrium, or a completely extracardiac tube. So this is a conduit attached from IVC, which takes the blood directly to the pulmonary arteries, and the Glenn has put the SVC blood to the pulmonary arteries. So the entire venous circulation goes to the lungs directly without the intervening right ventricular pump. And whatever single pump, whether it's the right ventricle or left ventricle, that is used to pump blood to the body. So this is the final pathway of Fontan. Now, a quick slide at intervention timing. When do we intervene for all these defects? Now, when a VSD is large, there are a lot of misconceptions, I think, about the timing of intervention, and this is very, very important. The timing of these defects is key. So when a VSD is large, I see a lot of misconceptions about operating them at 5 years of age, or, when the child is 15 kilos and so, but that's not the case. Large VSD should be intervened very early, actually, 1 to 3 months, definitely by 9 months, because we know that pulmonary vascular obstructive disease starts with large VSDs early. And then if there's a moderate VSD that is restrictive, meaning there is no pulmonary artery hypertension, we could wait for some time. And the smaller ones, we don't close them because they close on their own. The right age for ASD is usually 3 to 5, preschool years. And we do a lot of device closures. Sometimes a smaller infant may have to undergo ASD closure if they are symptomatic. Now, obstructive lesions, usually when you find them, like coarctation and pulmonary stenosis and aortic stenosis, depending on the gradient, we fix them. Tetralogy of Fallot, typically, again, in this part of the country, we're still doing it around 6 months, but neonatal repairs have been attempted. And single ventricle, just the steps I went over is done in the newborn period. The bidirectional cleanse are done around 6 months of age, and the final Fontan is done around 2 to 3 years of age. Looking at the transposition of great arteries, this is one condition where it needs an early neonatal repair. Less than 3 weeks of age is ideal. When there is a VSD associated with transposition, we wait for a little longer, about 6 weeks. TAPVC should be addressed at diagnosis. The obstructive ones are, of course, very critical, and it's an emergent operation, but the unobstructed ones also should be operated at diagnosis. Truncus arteriosus, which increases the pulmonary blood flow severely and can lead to early pulmonary vascular disease. We intervene at 3 to 6 weeks, and the AV canals usually are repaired by 3 months. Now, how about these children? After repairing, how do these children do? Now, there are a set of repairs, corrective, which do very well, like your ASD, VSD, PDA closures. They do very well without any great long-term consequences. There are some that could have some consequences and need reoperation, and then there are some more which can be quite intense in follow-up, and likelihood of reoperation is high. So these children and our growing adults can develop complications like systemic right ventricular failure, valvular problems, reobstructions of the operated areas. Fontan, of course, has many complications that I may not be able to address now, and then arrhythmias. So these children do come back for revision, either surgical revision or pulmonary valve replacements, which we are now doing catheter-based, and they can have several conduit revisions. So these children, almost, these two categories need a lifetime follow-up. So I had some take-home messages. CHD is amongst the commonest birth defects. Results in significant infant mortality. The infectious diseases, the diarrheas, LRTIs are coming down, but CHD remains an important cause of infant mortality. And most of the sinister defects, like I mentioned, present early after birth. So they tend to be very critical at birth. And despite the bewildering variety of CHD that is out there, broad physiologic categories, like I mentioned, are limited, they are understandable and applicable. So if we apply a physiological concept to each of the heart defect, then it becomes simpler to manage. And technological advancements have tremendously improved our outcomes. A number of Indian centers, as I mentioned, can now deliver outcomes that are comparable to international standards. And timing of intervention is key. I cannot emphasize much more about this timing. It not only decreases your neonatal and infant mortality, but it also prevents Eisenmenger syndrome, which is largely due to late correction or late presentation of CHDs. Then long-term concerns do occur, and they merit careful follow-up after correction of many CHDs. Thank you very much.
Thank you very much, Kavita, for a wonderful and clear talk, taking us through a whole lot of complex issues. We're going to move on to our next speaker, because we'll have the question and answer session at the end, if that's okay with you. But first of all, I think we should just give her a good clapping hand, really. So thank you very much. Our next speaker, it's my privilege to introduce Dr. Krishna Kumar. Is Dr. Kumar there? Hello.
Yes, there you go.
Oh, hi. Sorry, I couldn't see you. Great, because you were held up a bit in the traffic, so it's great that you are there. Dr. Krishna Kumar is clinical professor and head of the Department of Pediatric Cardiology at Amrita Institute of Medical Sciences and Research Center in Cochin. He's also honorary advisor and distinguished research professor at the Public Health Foundation of India and Center of Digital Health. He helped to establish the Pediatric Heart Program at Amrita Institute of Medical Sciences in 1998. And under his leadership, the program has acquired global reputation in quality of clinical services, research, and training. In 2014, the center was awarded BMJ's, that's British Medical Journal, Award for Quality Improvement for delivering outstanding clinical outcomes. Dr. Kumar is currently serving as co-chair of the World Heart Foundation Policy and Advocacy Committee for Rheumatic Heart Disease. He has published more than 250 index original and review articles and edited 4 major textbooks. So we're very fortunate to have you giving us a talk, and he's going to talk to us about rheumatic heart disease in children. Dr. Kumar.
Thank you for that very kind introduction. And again, it's a privilege to be a part of this very august group. And I'm going to try and see, it's probably not possible to cover every aspect of rheumatic heart disease. So I would look to try and see if I can cover what is of real interest and what has really changed about the heart disease. Are you able to see my slides?
Yes.
Yes, thank you. So I would restrict myself to a few specific areas so that I think we can allow then time for discussion. There has been some changes in etiology and pathogenesis, more or less conceptual changes that I would share, and that could have changed in the last 15 or 20 years. The epidemiology of the disease has changed a lot, and that needs to be understood. And a lot of that epidemiology change is part of my own work that I have done in this country. And then the diagnostic criteria has changed, and that's been revised since the last revision came out, 2015. And if possible, I'll try and bring in some illustrative case examples and vignettes that would be interesting to the audience. I would not try and cover every aspect of rheumatic heart disease because it's not feasible here, but I think these are the areas that would be of interest. I thought I can just throw up a few questions. I don't necessarily seek the answers right away, but I just use that to stimulate thought. The first question that I have is, which of the following statements about rheumatic fever is true? It's the only significant long-term consequence of rheumatic fever. The majority of patients will recall 1 or more episodes of rheumatic fever in the past. The commonest associated manifestation of rheumatic chorea is arthritis, and group A streptococcal infection involving both oropharynx and skin have equal likelihood of producing rheumatic fever. So these are some questions that I'm just going to throw with the idea of stimulating you and making you think about this. And we can revisit it at some point for the answers, but I just thought I would ask you this question. Now, the definition of rheumatic fever is that it's an acute inflammatory disease following group A streptococcal infection. Now, it used to be limited to the pharynx, but now skin infection is also considered fairly significantly as a contributor to the occurrence of rheumatic fever. Perhaps not so much in India, but definitely in many countries, particularly in Australia and in the Pacific Islands, there is an association with impetigo. Damage to the heart valves is rheumatic heart disease, and it occurs after repeated attacks, but can occur after a single episode, or some can even occur without an episode being documented. And that's the thing that's really increasingly apparent. So when we talk about rheumatic heart disease, we talk about the epidemiologic triad, we talk about the vulnerable host, and the vulnerable host is somebody, a patient who may actually have a very minor genetic predisposition, but is usually between the ages of 5 to 15. The agent is always group A beta hemolytic streptococcus, either in the pharynx or sometimes in the skin. The environment is very important because rheumatic heart disease is now increasingly apparent that it is involving the poorest. So there's something to do with the living conditions in the environment, the access to health, the poverty, all that seems to sort of predispose to rheumatic heart disease. So these three come together, and it's very, very, very important not to separate the occurrence of this disease from the environment of the patients or from where the patients, the social background. It's terribly important to consider that, not just in terms of understanding the etiology, but also to understand and manage these patients. So this was the traditional hypothesis, a linear hypothesis where sore throat led to rheumatic fever, with carditis, with recurrences leading to rheumatic heart disease. This was the kind of thinking that went on for many, many, many years. It is also apparent that rheumatic fever is basically a endothelitis. It's a diffuse endothelitis involving a variety of endothelial and epithelial linings, mesothelial linings. So you get valvular damage, you get pericarditis, you can get pleuritis, you can get abdominal pain from peritoneal inflammation. And this is a very widespread response. And you can, of course, get synovial inflammation from and resulting in joint pains, and you can get involvement of the linings of the cerebrospinal fluid, and that is in some way linked to the chorea. But what is interesting is that only the valvular involvement is what leads to permanent damage. So that answers the question that I had asked right in the beginning. The only long-term consequence is heart valve damage. And that's very important to recognize. Now, an alternative hypothesis is emerging because we've started to see patients who do not have clear history of rheumatic fever, who develop rheumatic heart disease, heart valve disease. We have started to see patients who never recall a single incidence of rheumatic heart disease, and yet you have pretty significant rheumatic heart disease. Also, we have realized that impetigo can also predispose to rheumatic heart disease. So you don't necessarily have documented episodes of rheumatic fever, but you have patients who come with rheumatic heart disease over a period of time. And this is the change in hypothesis, that sort of understanding of the way the disease progresses, that we've come to accept. The other real change that has happened in rheumatic heart disease is the epidemiology. And it's very important to understand this, internalize this, and recognize what has changed. Who is affected today by rheumatic heart disease? So when you report rheumatic heart disease today, you have a situation where you no longer sort of just look at the most overt disease. You also look at the covert or the asymptomatic or the latent disease. And it's very clear in the last 10 years that a large number of patients in endemic populations have disease without actually clinical manifestations, without even audible murmurs. We call them subclinical rheumatic heart disease or latent rheumatic heart disease. When they have obvious manifestations, then we call them symptomatic rheumatic heart disease, and the most severe of these need treatment. This is the global burden of rheumatic heart disease, a paper that was published in the New England Journal of Medicine in the 2017 by Dave Watkins from Seattle. And it shows a very clear geographic divide, which clearly limits rheumatic heart disease to the relatively poorer nations, and not just poorer, but also the ones which have the lower human development index. And it's almost mirroring human development index. If you just look at these countries, the disease, although it's a bit of a generalization because you have to look at it in a more nuanced fashion when you try to come to countries like India, but you can see that the countries that are slightly lower on the human development scale are all painted in green. There's always a limitation or of oversimplification when you paint countries as a whole, but you look into India, and that's what we did when we did our research in rheumatic fever. We did the world's largest registry studies in rheumatic fever in India, starting in 2000. And this was the Jai Vigyan mission mode study, where we found that parts of India, like Kerala, the disease has almost gone away. And in the parts where the human development indices are lower, the disease is still prevalent. And this is sort of reflected very nicely. And you have to understand that today, it's not just people are not divided between regions. It's actually rich and poor are living very next to each other, very close to each other. And essentially today's large cities are all microcosms of the globalized world, where you have all bits of extreme poverty and affluence living right next to each other. So what you see is very interesting. This is a study by Dr. Anita Saxena, which she looked at the echo prevalence of rheumatic heart disease in in rural schools just next to Delhi in Vallabhgarh, and then looked at rural private schools, rural government schools, and the schools of Delhi. And there was a clear gradient of the occurrence, the incidence of clinically silent or subclinical rheumatic heart disease in a very carefully conducted study in children. This is a study that I was a part of from the Australian indigenous populations, and we found something very interesting, very striking. See, amongst the aboriginal populations, the indigenous populations, the incidence of rheumatic heart disease was exceptionally high. And whereas the non-aboriginal populations, which are shown below, it was almost non-existent. So the incidence rate ratio, that is the ratio between the aboriginals and the non-aboriginal population, was 68.8. And these were people living right next to each other. So incredibly striking data that suggests that this is a disease of marginalized populations. So who's affected most by rheumatic heart disease? The rural poor, the urban poor, and perhaps to some degree, the urban middle class, but largely it doesn't affect them. And affluent, it almost never affects them. Now, what has happened in the last 50 years is that the tertiary cardiovascular healthcare professionals have all moved to serve the affluent. As a result, this group of 4 billion people who live in the poorest parts of the country, they don't have access to real quality tertiary care. So what has happened is, since we as cardiologists live now in the urban affluent areas, this disease has slipped out of our collective consciousness. We don't think it is prevalent. But if you really look for it in the parts where it's prevalent, you still find lots of it. And that is the real change. It's not so much that the disease has disappeared, but the disease has moved to populations that we don't no longer look into. So that's the real change in epidemiology that has happened. And we need to be cognizant and aware of this change and not make a statement that the disease is on the decline until we have some very robust data. Now, what's different about rheumatic heart disease diagnosis? It's very essential to have recognized the fact that you need to know the prevalence likelihood of the disease in the population when you apply the diagnostic criteria. This is what is known as the Bayes theorem. So it's very important. I'll ask another question to stimulate you guys. Which of the following statements about the 2015 revised Jones criteria for RST is true? 1, carditis needs to be identified clinically through physical examination to be considered a major criterion. Polyarthralgia is also now a major criteria in high-risk populations. Minor criteria are identical for low and high-risk population. And there is what is known as the essential criteria, where you have to document the evidence of group A streptococcal infections. That can be waived for high-risk population. So you need to just pay a little attention to this question, and I'll come back to the answer as I discuss the next session, next set of slides. So what's new with the 2015 criteria? There are clear differences between high risk and low risk. So earlier, we never made that distinction. We used to apply one single criteria for all the populations, and that created a lot of problems. So now we have slight differences in the high risk populations where we are more liberal, and low risk populations where we are a little more strict, so that we don't overdiagnose in low risk and we don't underdiagnose in high risk. And more importantly, we have started to recognize the importance of subclinical criteria. So if I just go back to the question, the answer to this question is A, that carditis, this is not true. Sorry, A is false, where carditis now no longer needs to be identified as clinically. It can also be identified through echo. So even if you find subclinical carditis, it qualifies as major criteria. The correct answer to this question is B, where polyarthralgia now becomes a major criteria for high-risk populations. So you're more liberal for high-risk populations. Minor criteria are not identical for both the population, and you need to demonstrate streptococcal infection. So let's go back to the criteria. Well, the initial episodes of rheumatic fever require 2 major and 1 major and 2 minor, just as before. But recurrent episodes, it is okay to have 3 minor criteria also. So either 2 major and 1 minor, or one so usual as what we had said for the initial episodes, but we are able to accept even 3 minor criteria. Essential criteria cannot be waived off because that requires the previous evidence of rheumatic. There are only 2 exceptions to that. And if you demonstrate rheumatic beta hemolytic streptococcal infection, that is necessary. So who are these 2 populations? So low risk population is when the rheumatic fever incidence is 2 per 100,000 or less, and rheumatic heart disease prevalence is 1 per 1,000 or less. So less than 1 per 1,000. Whereas high risk populations are greater than 2 per 100,000 school going children of rheumatic fever. And so the cutoff is 1 per 1,000 for rheumatic heart disease. Again, it's a bit arbitrary. This is obviously you have to make some kind of cutoffs. So this is the cutoff that the group decided. So based on these cutoffs, now these are the criteria that we have for low risk versus high risk population. The low risk population requires you to have carditis, which could be clinical or subclinical, but it requires you to have polyarthritis only. Chorea, erythema marginatum, subcutaneous nodules. None of this has changed. High risk population, you're more liberal with arthralgia. So you're willing to accept arthralgia, you're also willing to accept monoarthritis. So that's one difference that has happened with, and then with the minor criteria, you're again a little more liberal. You want a slightly higher grade of fever for low risk populations. You want a little more ESR. And of course, you are more liberal with the high risk population. But you know what? You have to apply your clinical sense. These are just guidelines. And you need to put that all in context of the patient's overall picture. Then you get the clear idea as to what is significant, what is not. So with this in background, I just thought I'll share some case examples and vignettes. So here is an example of a 8-year-old boy from a rural family in southern India. Now this boy came from Kerala, but from a tribal settlement in the district of Idiki, which is relatively poorer with less access to healthcare. Child has fever and high-grade fever for last 6 weeks, migratory polyarthralgia, not arthritis, starting 2 days after the onset of fever involving both the knees and ankles and elbows and wrist. And he's got orthopnea, limitation of physical activity for the last 1 week. So this is his presentation. And the child is afebrile, somewhat tachypnic. You have a pericardial rub, clinical evidence of severe mitral regurgitation with liver enlargement, but no joint pains. But what is striking is this. Now, these are one of the most striking examples of subcutaneous nodules that you will ever see. They are classically located on the extensor surfaces, right over bony prominences over the vertebra, over the scapula, over the knee, folded knee, over the forehead, over the mastoid, over the elbow. And they are really, really very striking. This boy obviously had a mitral valve involvement. This is an apical 4-chamber view where you can see the regurgitant jet of the mitral regurgitation, which is classically directed posteriorly and laterally, very typical of rheumatic heart disease. Of course, he had this beaded appearance on this aortic valve, on the mitral valve, which suggests possibly, these what is known as verrucae. And then, of course, you have a PR interval that is prolonged on his ECG. And in addition, he had this somewhat thickened cords that you can see out here, suggesting that he had been having a background rheumatic heart disease, and this was a recurrence. Now, these thickening and beaded appearance is what is known as verrucae that actually happen at the margins of the valve leaflets during acute rheumatic fever. They are different from that of endocarditis, which are much larger and much more mobile. Of course, when we treated him, all these nodules just disappeared. Within a month after follow-up, they'd all gone away. And that's very characteristic of subcutaneous nodules, which are painless nodules that just go away. And they typically happen during recurrences of rheumatic fever. Of course, this is something that is seldom seen, but my friend, Dr. Jayaranganath, who sees a lot of rheumatic fever in Bangalore, every month he sees 3 to 5 cases, got this rare phenomenon of erythema marginatum, which is classical out here. What you see is these classic serpiginous, non-pruritic sort of rashes that appear on the trunk typically, and sometimes on the proximal limbs. And they are very evanescent. They come and they just go away. And this is very, very characteristic and of course, very rare, but typically we tend to miss them in India because of the dark skin. But if you really carefully look for them, you can find them. And of course, this is unforgettable. What you see out here, this is a child who came to me, again, very distressed by the fact that she just could not control herself. And this is absolute classical Sydenham's chorea that you see out here. I had to get formal permission from the family to show this because it was a source of considerable source of embarrassment that I explained that this is something that we rarely see. The child had gotten better, so the family actually agreed for me to share this video with you all, and because they were so happy and thankful when the child got better. It can be very subtle, you know. Sometimes you just have to ask the child to write her name, and you'll find that the handwriting is substantially different from the usual handwriting, and that will tell you, okay, maybe this is subtle chorea. So quickly, I'll just almost at the very end of my talk, what are the following are true about the major criteria. Subcutaneous nodules are commonly associated with the first episode of rheumatic fever. Chorea is rare in adults, except with the exception of pregnant women. Arthritis is characterized by joint effusions, and rheumatic carditis is often associated with ventricular dysfunction. So I'll dwell a little on this question. The answer to this question is B. Chorea is rare in adults, but with the exception of pregnant women. A, subcutaneous nodules is commonly seen in recurrences. Arthritis of rheumatic fever is just pain, intense pain, not much by way of effusion. Disproportionate pain, which just dramatically melts away with aspirin. And then, of course, rheumatic carditis is never associated with ventricular dysfunction. It is a phenomenon, it's predominantly valvulitis. The component of myocarditis does not result in ventricular dysfunction. It's something which is almost now become an axiom. A quick few slides about rheumatic heart disease, because these are pathologic specimens and I wanted to share some of my own work with you here. This is a path specimen from rheumatic heart disease that you see out here. And this is a normal heart valve that you're seeing, where you see these distinct fine cords, and you can see the distinction between the cords and the leaflet margins. What happens in rheumatic heart disease is this extensive fusion and thickening of the cords that happen, caudal apparatus, and that fuses with the leaflets. That produces the scarring that you see in these patients. That's the damage that happens to these patients. Now, with three-dimensional echo, we are able to actually demonstrate this phenomenon. We can see the thickening of the cords that you can see in these patients, and you can see the pillar-like cord apparatus which fuse with the valve leaflets. So almost an absolute recreation of pathology is possible now with three-dimensional echocardiography that I found it very exciting to share with you. So here is the fish mouth appearance that you see typically of rheumatic heart disease with thickening anterior leaflet and the posterior leaflet. And the closed leaflet is all regurgitant along its margins that you're seeing out here. More dramatically, you can compare it with pathologic specimens and find the extraordinary correlation that you see here. And here is a video that shows this actual thing in real time that tells you exactly what goes wrong. And this is what we are trying to prevent. This is something that needs to be prevented. Once it happens, it's rather difficult to treat. So the essence of knowing about rheumatic heart disease or rheumatic fever in childhood is to prevent what it does to them subsequently in life. So parting thoughts, the epidemiology of rheumatic heart disease has changed. It's become sequestered within marginalized and poorer populations. And it's slipping away from our collective consciousness. Jones criteria is now very context specific and needs to be applied in context to the patient where the patient comes from. I think that applies to everything in medicine, but here it's really clearly spelled out. Echo identifies subclinical disease, and that's become important, particularly from identifying patients. And the real drug that makes a difference is actually just penicillin. Nothing else really changes the outcomes. So giving penicillin to these patients regularly after the first episodes does a lot in prevention of long-term valve damage. That's all I have to say today. Thank you so much. I'll just stop sharing the screen.
Well, thank you very much, Dr. Krishna Kumar, for a fascinating talk. I really certainly enjoyed that. Very clear, very good illustrations, etc. So thank you very much. And we're now going to move on to a question and answer session. And I would like to ask my colleague, Dr. Habib Burabala, to start the session. We've had a number of questions in on the chat. Dr. Burabala, would you like to start, please?
Sure. No, thank you, Professor Sandhu, and thank you both the speaker for fascinating talk. So yes, we do have few questions, and those who haven't still, had an opportunity to ask or post any questions, please do so before we conclude. So I might just start with the first question with Professor Krishna Kumar. I think the question was, is there any particular pattern description on time or joints involved for migratory polyarthritis?
Yes, there is. It tends to involve the relatively larger joints. It spares the spine. It spares the cervical spine, the back, the lower back. So those joints, when they're involved, it should lead you towards another diagnosis altogether. You've got to think in terms of seronegative spondyloarthritis. It also spares the relatively small joints of the hand that would point towards rheumatoid arthritis. The typical joints are shoulder, elbow, knee, ankle. These are the joints that are most typically involved. Now, the pattern, it's classically migratory, but that's not something that you see all the time. You can have multiple joints at the same time, or you can have a sequential involvement, or sometimes you could just have monoarthritis, or you could even have polyarthralgia.
Dr. Kavita, do you want to add anything to that? Could you unmute?
Thank you, Professor Krishna Kumar. I might start with another question. Dr. Kavita or Dr. Krishna Kumar, one of you, would be good if you could answer. The question is there any role of losartan or Navy below in congenital or aortic stenosis?
Not in severe aortic stenosis, because in losartan is a vasodilator. And if you give it for severe aortic stenosis, you would produce hemodynamic compromise. But losartan has been shown to retard the progression of aortopathy. So if your aortic root is dilated, and that happens as an association for patients who have bicommissural aortic valve, a certain proportion of patients have dilated aortic roots, and there is some evidence to support the use of losartan that prevents the progression of aortic root dilatation. That is the basis of using losartan. Now, nebivolol is basically a beta blocker that has an alpha, also has a alpha blocking effect. So that is a drug that can be used. It again should not be used in isolated aortic stenosis at all. But a pure beta blocker can be used for patients who have aortic root dilatation, because again, that it retards the progression of aortic root dilatation. But both these drugs cannot be given if there is severe aortic stenosis, because that will result in a reduction in cardiac output.
I think agree with that. In children, only presence of aortic root dilatation we're using, but I think adults use these two in aortic stenosis because it does promote some remodeling of the heart and decrease the inflammation, which is a pathology for adults. And I've seen them used before and after aortic valve replacement. So I think the pathology in adults is somewhat different. In pediatrics, we've just been using when there is dilatation of the aortic root.
Thank you. There is another question. How to confirm the device has not moved after it's been inserted? I think one of the participants had that in that experience. So how does that happen?
Yeah. I mean, after device implant, at the time of implant, we make sure, that the ribs are all well caught and the device is sitting well. And typically, if an embolization happens, it's usually within the first 24 hours. And we do monitor the patient closely, and everybody gets, a repeat echocardiogram the day after the procedure before we send them home. So rarely, yes, it has happened out of hospital, but mostly it's during the observation period. And I think the key is, to make sure that it is sitting well at the time of deployment.
Sure, thank you. Professor Krishna Kumar, do you want to add to it?
No, I agree. We just need to be very meticulous about the device once it's been placed, and you got to be absolutely sure. We tend to perform an echocardiogram a few hours after the procedure and also the next morning. And we make sure, and we have ways to tell that you can actually, the device is in good position.
Thank you. There was another question about, certain procedures such as TAVI and TAVR in adults. Are there any, any talks about them being used in children, and so when?
Not for the aortic valve. I don't think we are yet at a situation where we can consider replacing the aortic valve percutaneously, but the truth is that TAVI actually grew out of a procedure that was created for pediatric cardiology. Dr. Philippe Bonhoeffer actually devised the technique for the pulmonary valve implantation. And that is being used extensively in the post-op tetralogy patients. Now, Dr. Philippe Bonhoeffer's work was then identified and developed and adapted to produce the TAVR, which is the aortic valve implant that is being used extensively in adults now. But we don't use it in children for aortic valve. Pulmonary valve, of course, yes, we do implant pulmonary valves fairly regularly in patients who require them.
Thank you.
Can I ask a question?
Yes, please do.
Okay. I mean, we hardly ever see rheumatic heart disease in the UK. And you showed that data, whereas Delhi, the incidence is much less. Do you think there should be a public campaign to try and prevent rheumatic heart disease? Because it isn't, I mean, it's a bit more complicated than just poverty. It must be people not presenting, not seeing anybody, not having their sore throat when they get one, or they're ill initially, being aware that that can be something serious and going to see a doctor, because really that would be the best way of treating it.
Yes,
and the World Health did pass something 3 or 4 years ago when they were going to try and integrate an international response to this. I wondered whether you like to say something about that, on what's happening in India. And number 2 was really the pathophysiology of Korea. Do we know exactly what happens? Why?
So the first question relating to how we should try and so the World Health Assembly, actually, it was more recent, fairly recent, that resolution was passed. Just a few days ago in Geneva, I was there when we actually adopted this decision to try and bring in a public health campaign for regions that have very high prevalence of rheumatic heart disease. Now, that's very easy when your country as a whole has rheumatic heart disease as a big problem. That's true for a lot of African countries. It's far more difficult when you try to do it in a country like India, where in Kerala you have a rheumatic heart disease sort of like in the UK, hardly there. But if you take a state like Chhattisgarh or Orissa, then you have rheumatic heart disease as a big problem. Even within those areas, there are districts with very high prevalence and there are districts with a relatively low prevalence. So we can't come up with a plan for the whole country. So the larger and the big complex countries cannot be tackled in this fashion, because it would not make any sense in Kerala to have a rheumatic heart disease campaign. What has to be done is a very nuanced approach that is targeted at populations with the highest disease prevalence. And that needs data. You need to have data on where is the disease burden most significant, where is the disease burden not so significant. So that's an issue that's not so easy to sort out. You can find surrogate ways of determining the disease prevalence by actually doing surveys on populations and seeing the evidence of subclinical carditis. But that's all not been very well validated. So it's not so easy. The real answer, to be honest, yes, it seems like a disease that can be tackled through public health campaign, but the real answer is primary care. It's very interesting how rheumatic heart disease just goes away if your primary care improves. Nobody tried to make it go away in the state of Kerala. There was not a single rheumatic heart disease campaign of that sense, but the disease went away. It went away in Sri Lanka. It went away in so many other countries. Just it went away in the UK without actually there being a campaign. Because if you improve primary care, people get prompt attention to sore throat, and you break that cycle. You don't create epidemics of streptococcal infection. So just by improving primary care, improving overall state of health, you can actually, the disease goes away. It's only on small selected countries like Cuba and like in Guadalupe and a few other countries where a targeted campaign was used to try and eliminate rheumatic heart disease. But that only works if you have good primary care. It doesn't work otherwise. And on the reverse, in Soviet Union, in the breakup states of Soviet Union, when primary care just fell apart after the breakdown of the communist government, rheumatic heart disease came back. So this is a very interesting situation. It's extremely complex and nuanced, but the bottom line really is that it reflects how good your healthcare system is.
Thank you.
Thank you. I think we might be towards the end. We might have one or two last questions if everyone is happy to take it. There are two questions. I think there is a question, on the role of paracetamol in PDA. If Dr. Kavita, do you want to answer, please?
There is a role of paracetamol in PDA, and as with other medications that have been used, indomethacin, ibuprofen, they have more renal toxicity. So I think paracetamol has a safer profile than the others was being used.
Thank you. And the second question is ECG changes. If I read it correctly, I think what's trying to say is, with a post-operative case of congenital heart disease, how to differentiate if there is an ischemia between baseline and post-op?
Yeah, that can be difficult on occasion, but it's always good to compare with previous ECG. So, I mean, I do it all the time because there are changes in that. So compare with the baseline and see if there are any changes.
Thank you.
All right. Any more questions? Otherwise, I'll close. Okay, well, I think that's the end of this really, really good session. I really enjoyed it. Lots of topical issues discussed, and a lot more progress to be made in all sorts of ways in India. But it's good to see that there is a lot of progress being made, and children with cardiac disease are mostly getting good care where they are nearer larger centers. So I just want to thank everybody involved in making this session successful. I'd like to thank you, Dr. Habib Buravala, for joining us after midnight from Australia. I'd like to thank Dr. Krishna Kumar and Dr. Kavita for both of them were excellent talks. So thank you so much. I'd like to thank Dr. Ramesh Kumar from IAP and his colleagues, and Dr. Anupam and Dr. Tandon from GAPIO for organizing these sessions, and long may their working together continue. I also want to thank the IT team who make it really possible. They're the behind the scenes people, and so I want to thank them. But most of all, I want to thank you, the audience, because without you, the event wouldn't be there. And I hope you've not only learned things, but have enjoyed the session. So thank you very much for giving up your Saturday evening to join us. So I'd like to thank you all. So if we can just give a hand to all the people involved. Thank you very much.
Thank you.
Thank you.
Can all leave now. Thank you. Nice to meet you all as well.
Thank you. Pleasure.
Thank you very much. Thank you very much.
Thank you.
Thank you, Dr. Tandon.
Thank you, sir. Thank you, Dr. Bhavinder. Thank you. Thank you, Dr. Krishna Kumar and Dr. Kavita. And thank you, everybody.
Thank you.
Lovely.